CPD webinar series organized by the Society for Health Research and Innovation. Before going to the today's lecture, I would like to introduce you with some housekeeping rules. The webinar link will be available from 9 a.m. to 9:50 a.m. to join. No late attendees will be entertained thereafter. Each attendee should have been attended till the end of the webinar to obtain the certificate for CPD points, and the CPD points are strictly adhered to the NCCPD guidelines. And I kindly invite all of you to mute your videos and mics during the lecture, and if you have any question, you can ask it at the end of the lecture, or you can type it into the chat function. Or if you have any specific question, you can email us on office313@gmail.com. Thank you for strict adherence of the CPD regulation and your kind compliance. The topic of today's lecture is post-COVID lung disease. Our guest speaker is Dr. Vipula Bataduwaarachchi, Senior Lecturer and Specialist in Respiratory Medicine. He is the Deputy Director, Respiratory Center, Faculty of Medicine, University of Pune. Over to you, sir.
Thank you. So, good morning to all of you. So, I will talk to you regarding an important topic which is becoming again quite important, and it's quite a never-ending topic. So, basically, actually, I will touch mainly on the post-COVID lung disease, but I will try to explain to you the main points in the COVID story. I was actually working in Sri Lanka during the first epidemic. Then during the second epidemic, I was in UK. So I have quite a comparative idea about what has happened. So I will explain to you basically the key issues related to the COVID infection. I will touch mainly on these topics. What is long COVID or post-COVID, then what is post-COVID lung disease, which is almost quite different, and pathological sequelae of post-COVID lung disease, again, which is not very unique or clear-cut. Then the diagnosis of post-COVID lung disease, which is mostly a diagnosis of exclusion. Then the management of post-COVID lung disease, which is again not very specific. Then what is relevant to our context, because there is a considerable difference in our context compared to some of the other countries, especially subtropics. So, right. So what is meant by long COVID? Now, long COVID is basically defined as signs and symptoms and conditions which develop after the initial episode of COVID infection or the SARS-CoV virus 2 infection. Most of the times the infection, the duration varies, but if the symptoms persist after like 4 weeks, then we consider it as kind of long COVID for continuation. And usually it is multisystemic. And the progression is quite different. Sometimes it's relapsing and remitting. Sometimes it's gradually progressing or worsening type of presentation. So it's highly variable. Now, what is different in this COVID infection? Actually, COVID virus is very virulent compared to other coronaviruses or even SARS viruses. That is basically due to the mutations profile of this virus. And we are still not clear how this virus evolved or escaped. So this is quite unique and quite virulent compared to other viruses. So that was the reason for this kind of pandemic and kind of uncontrollable and severe form of disease. So this is basically affecting multiple systems compared to rather than confined to respiratory system. So that has made things more complicated. So even post-COVID infection is multisystemic. Then long COVID is not a single entity. So there are a lot of overlapping between existing lung diseases and overlapping between symptoms, and also overlapping between other related things like underlying psychological or other social factors. So it's very complex kind of entity. So this is the overall impact of COVID. So 5 million deaths. So it's very significant in a infectious disease. So then the post-acute sequelae of COVID-19 has caused multiple issues. It has mainly actually overburdened all the kind of healthcare sector capabilities like ICUs, ward settings, then the clinics, which has actually affected treating other conditions, other diseases, then the economy, patient-wise, quality of life, long-term disability, then the economy. So it has a huge burden, but we don't have data on our Sri Lankan context. What I have observed is our COVID impact is comparatively less because in UK, the hospital I worked, there were thousands of patients admitted at one day, like one time. So in the ICU, about 400 patients. So it was very significant in that region. There are multiple theories for that. Probably vitamin D is one reason, and the pool of coronaviruses is very common in our region. So we may have partial immunity. We have to the coronaviruses. So our severity of the disease is comparatively less, fortunately for us. But still, we don't have enough data to have a kind of uh, proper assessment of the impact. So long COVID is, sorry. Now the range of symptoms, the presentation is also quite wide. Some are actually asymptomatic, some are just having febrile illness. At the other end of the spectrum, we have severe form of disease, ARS to death, ARDS to death, sorry. So when a patient fall into this category, it's very difficult to save their life. And mainly this is due to interaction between the genetic profile, viral factors, and other comorbidities. What I have seen is healthy people, there are different categories of or clusters, like patient clusters who fall into severe form. Actually, one category is young patients with possibly having good immunity. So they are having overactive immune system interacting with the virus, causing severe damage to the lungs. Some people ending up with uh, bilateral emboli and bilateral pneumothoraces, plus severe ARDS. So that type of patients very difficult to save. Other categories like patients with immune suppression like diabetes and alcohol and smoking. And also elderly people with chronic lung disease also has got this had this increased risk. So those are the kind of, and the other one is pure genetic risk. I have seen patients from the people in the same family, all of them died in the ICU, something like that. So there are multiple or complex interaction between this environmental and viral factors. So post-COVID lung also quite similar. Their progression is very much variable. So I was actually part of the recovery trial, which was the leading trial in UK. So it was basically on treatment, not on the assessment of the post-COVID status. So you can see now 40% of them had 5 to 6% persisting symptoms after COVID-19. This was a very common complaint after COVID-19. Actually, some are attributed to, not related to COVID. That's mostly psychological and or exaggerated by psychological background. So it's very difficult to identify real post-COVID, especially in patients with other chronic lung diseases. Other thing, the duration is very much variable. Most people actually recover quite quickly when they mix up with the normal environment. But some people tend to have kind of uh, acquired sick role for months, weeks, and months. There are other things like people trying to get medical leave because a lot of attention paid on COVID. So that was another kind of challenge for us. Patients coming with various other kind of hidden ideas. So it was quite complex. Uh, the mixing up with existing lung disease is also quite complex. For example, patients with asthma and other obstructive lung diseases and restrictive inflammatory, lung fibrosis patients had exacerbation. So we were not very sure what really causing exacerbations. Anyway, they were managed as their normal existing lung disease, but even though these are overlapping, otherwise, there were not much management-wise. There were not much difference. Uh, so these are the symptom burden of post-COVID respiratory infection. One thing is persisting COVID symptoms. This mainly happens in patients with who had severe infection. I will show you how it progresses, how it develops and progresses. Especially some patients acquired secondary lung damage due to prolonged oxygen treatment, ventilation, different type of ventilation. So that was the only way to maintain the oxygenation. So COVID patients subjected to prolonged ventilation that per se caused serious problems, maybe irreversible problems. Then worsening of the existing diseases, any damage to the lung with fibrotic changes will persist most of the times. Then lack of attention to other diseases. Patients are not attending to, even hospital clinics are not conducted during this period for some of the diseases. So patients presented with exaggerated other diseases soon after the COVID infection. They had missed COVID, the clinic visit during COVID period, and it was a kind of burden, secondary burden. And also patients died due to the same reason, due to existing worsening of the existing disease. There's a psychological component, as I explained to you. It's again very complex. Majority of the patients had some psychological component. So they were exaggerating symptoms. Sometimes they were not aware that they are kind of exaggerating. That's also part of that. And sometimes symptom per se can exaggerate anxiety, especially breathlessness. Any patient with breathlessness will get anxiety. So very difficult to decide the proportion of contribution to the symptom. So you can see how complex this is. So careful assessment and methodological systematic approach is very important. So I'm very sorry, this slide is not very clear. So this shows the range of contributors to post-COVID respiratory symptoms. Actually, this virus had very unique mutations, especially this ACE, involving ACE, angiotensin converting enzyme gene. So that is why it actually affected vascular system, especially microvasculature. That leads to endothelial inflammation and various other complications like thrombosis, thromboembolism, increased coagulation, and also this myocardial injury. Myocardial injury also had multiple factors like respiratory distress per se can damage the myocardium. So direct viral injury also was the reason. So you can see it's multisystemic. But the main pulmonary pathology was ARDS and subsequent fibrosis, and also ventilator-mediated lung injury. Then viruses directly causing inflammation, organizing pneumonia was also found, and also cardiac injury, thromboembolism, and deconditioning. That is due to prolonged hospital stay and due to the prolonged viral disease itself, due to prolonged activation of the immune system. Then central hyperventilation, that is also due to chronic hypoxia. Patient get increased respiratory drive. And when we try to overburden the patient with oxygenation and ventilation, it can have multiple, damage to lung tissue rather than protecting. So careful adjustment of the ventilator was very difficult in these patients. We were going by like simple criteria, but that was not enough to adjust this oxygenation. So they ended up with multiple problems. Then post-COVID lung disease manifestations. As I told earlier, one key manifestation was organizing pneumonia. I will explain to you for who are not familiar with the term. Then acute respiratory distress syndrome. I hope you are familiar with this. Again, it's a little different entity which affect lung parenchyma and other pulmonary pathologies like pulmonary embolism, which was not really common in our setting, like compared to UK. Honestly, that subtrophic pulmonary embolism is quite high. They have probably genetic risk compared to us, but nobody believe it or nobody like to accept that. But there is obvious difference. Then pneumothorax. I have seen about more than 20 or 30 odd pneumothoraces due in the ICU. It was very significant number. Uh, Possible reason is this widespread inflammation involving this subpleural lung parenchyma and over-enthusiastic positive pressure ventilation. Some patients had bilateral pneumothoraces, so it was very serious. Patient with bilateral thromboembolism plus bilateral pneumothoraces. So we had very young patients with that type of lungs. So it was very serious. Then the secondary infections. When a patient is kept in the hospital for a long time, they are colonized with this resistant bacteria. Then our ventilator management, endotracheal tube management is not very very good, and patient can easily get serious lung infections. Comparatively, we are having more infections than UK. That's also again obvious thing. Their infection rate is quite less. There could be multiple reasons, but our infection risk is more. So you can see the difference in various presentations. The other problem that post-COVID interstitial lung disease, people try to kind of define this as a unique entity, but it's more or less the same overlapping condition with other interstitial lung diseases. Only the etiology is quite different. This is here the starting point is COVID virus. So I will explain to you in subsequent slide how this starts and progresses. Then, as I told you earlier, the survivors thing is now if 100 patients comes, significant number actually recover even though they develop kind of severe troublesome symptoms. But one category, they start falling into that danger area. So they start one early sign was that increasing lung shadows and hypoxia, early hypoxia. So these patients actually, what we did was in UK, we separated them into a observational intermediate high care. What my observation was in the high care, out of 12 beds, 4 patients died in one day, 4 patients transferred to ICU. So you can see that selected category had higher chance of moving into further deterioration. So this final category needed ventilation. We were ventilating them. Actually, we recruited them in trials, clinical trials, each and every patient. So they were given separate pathways like high flow nasal oxygen. It's slightly positive pressure device. I'm sure some of you may have experience. And also this CPAP, BiPAP positive pressure ventilation, and also if the patient is serious, then we go into intubation and ventilation. So this had, while protecting hypoxia, this had serious other problems like pneumothorax and infections. We call it ventilator-induced lung injury. Then, what is the underlying pathophysiology of COVID lung? It's not actually different to other lung parenchymal, the inflammatory disorders, but COVID infection was quite fast evolving and quite severe, especially affecting this immunogenetically at-risk individuals. There were no way to identify these at-risk individuals. That was the key problem. There were trials conducted on this area to identify genes. We also had a very huge database on genes, but we were not able to isolate, key genes. So it was a significant problem. It's quite common to any viral kind of infection anyway. So what happened is repetitive tissue injury activating this fibroproliferative cascade, which is the downstream of the inflammatory pathway. So once it is activated, it keeps on secreting these multiple mediators, fibroblast growth factors, vascular endothelial growth factors, transferrin growth factor beta. So that will activate fibrosis. Now, fibrosis again is a way of protecting the tissues, but it ended up with non-functional tissues. So there is something called transactivation or transformation of normal cells to fibroblasts. So that can exaggerate the problem. So it will cause more deposition of extracellular matrix and fibrosis. So tissue like very fine tissue like lung, this is quite disastrous. So that will cause irreversible damage to lung parenchyma. If the damage is widespread, that ended up with widespread lung fibrosis. So this is the problem. I have seen some patients develop very rapid fibrosis. I can remember one patient, within few weeks, months, he was oxygen dependent. But others, sometimes they actually regress. Initially, they have some fibrosis and soft shadows, but later they resolve, and they ended up with few scars. They were actually quite okay, and they were able to maintain normal oxygenation, although they had some exercise limitation. So the presentation was very variable. Then what really happens is this viral mediated damage and inflammatory damage can affect both alveolar epithelial cells as well as endothelial cells in the lung microvasculature, the pulmonary circulation. So it affects both the vascular side and the air side of the this membrane. So it's quite significant, and it causes severe VQ imbalance. That means imbalance between oxygenation and perfusion. So that's why they were very hypoxic, because it significantly affects oxygenation, the membrane. So once it is activated, patient fall into kind of severe hypoxia. In other lung diseases, you don't get that much of involvement in the vascular system at the same time, and also widespread involvement, except in very serious ARDS. So this is why COVID was very difficult to manage condition even in the ICU setting. Now you can see even virus can directly have the cytopathic effect on alveolar epithelial cells. So what they do is they go and kill the cell, damage the cell, and try to replicate inside the cell, and activate surrounding inflammatory media pathways in the surrounding area, the microenvironment. So this ended up with a disastrous inflammation. Now, as I told you earlier, this ventilator-induced injury. When you pump oxygen into a highly active, area where the inflammation is active, that will actually cause more tissue damage. but there is no other way to manage hypoxia also. Uh, so macrophages, cells like macrophages and these mediators, especially these fibrogenic mediators like interleukin 6, 1 beta, 18 TNF, flooding into this COVID lung, because we did a study on these markers, and these are very common in the found in the, I mean, with very high titers in these tissues, even in the plasma. So we can, this actually not very unique to COVID, but very high titers can have kind of significant damage. Uh, now, now I already explained to you how all these cells are involved in this inflammation, and also endothelialitis contributing to thrombosis. What I have seen is some patients get thrombosis in the microvasculature itself, which is not very clear in the CT scans, but they have very severe hypoxia. Other category, we could see that emboli, large emboli on bilateral vascular trees, pulmonary vascular trunks. In the UK, I don't know much about here, but it's very risk is quite less in our country. But in UK, it's very common. Patient ended up with bilateral emboli. Especially if a patient develops sudden hypoxia, sudden breathlessness, we used to do a CT scan, CT pulmonary angiogram quickly, and most of the cases we noticed large emboli. So this is just to show you, I mean, not to complicate further, just to show you how this is a whole functional unit of the lung is involved. Now you can see ACE2 receptor, that's the attachment point of this virus. So risk factors like genetic, smoking, gastroesophageal reflux, even this microreflux, leading to this severe lung damage, ARDS, villi, and the male sex, old age, and comorbidities like type 2 diabetes, hypertension, ischemic heart disease. Then severe forms like some identified genes, TYK2, OS1. I mean, you don't have to know these genes, but just to show you that there are genetic factors contributing. Then the ultimate problem in post-COVID lung was fibrosis and continuous remodeling. One problem is immune system is not able to switch off the inflammation. There are inhibitory T cells which usually switch off the inflammation. But when there is ongoing stimuli or genetic factors, sometimes this does not happen, and they keep on secreting inflammatory mediators. So that leads to long-term damage. So that is also depend mostly on the genetic profile of the person. So these are very difficult to manage cases actually. The potential therapeutics actually we have not used much, even in UK. We use tocilizumab in UK quite significantly, and in the trials we used multiple medications. But as per my experience, I'm not sure whether they improved due to tocilizumab or they just improved. There were not much significant difference in the trial results, but we used quite a lot. Then these are the post-COVID lung ended up with fibrosis. So there were option antifibrotic agents like nintedanib, then mTOR inhibitors like sirolimus, then immune modulation with these MABs, interleukin 6 or JAK inhibitors. So although they were named as potential therapeutic options, they were not used much. I have already described two viral mediated endothelial epithelial injury. This is actually the initial point of where the damage starts. That triggers cascade of immune pathways. We conducted one trial on factor factor 5, I think. Some of the hematological factors, uh, whether they are contributing. But one observation was sometimes even the inflammatory markers at higher titers, they were not really contributing to the inflammation. That's why some drug targets failed actually. So there were no correlation between the theta and the damage. So that was one problem. Then this megakaryocytes activation that actually affected mainly the vasculature. These are the or cells which produce platelets. So these are full of inflammatory mediators. So they can actually cause huge impact when they are attached to damaged tissues. Then mechanical ventilation, as I explained to you, it can further increase these fuels, oxygen plus even mediators. So you can see how complex this pathology in this condition. We tried multiple treatment. This is one reason steroids are quite useful because steroids suppress inflammation at multiple points. So steroids are quite helpful actually at various stages. So this is one reason. When the inflammatory pathways are widely activated, then there is a role for steroids. But when there is unique pathway activated, then we need a very specific targeted treatment. Then regarding this ARDS, identification of ARDS was very important. I mean, as I told earlier, the category of patients who develop severe hypoxia and rapidly progressive pulmonary shadows. So the initial phase is this exudative phase where we get hyaline membrane formation, that is inside the alveoli, we get inflammatory exudate. Then interstitial infiltration by multiple cell types, macrophages, lymphocytes. Then interstitial edema, cytopathic damage, and fibrinous exudate, that is from the hematological coagulation pathway. So that close off the functional unit of the lung. So when this happened throughout the lung, they ended up with severe respiratory failure. Initially hypoxia, type 1, then they might go into type 2 respiratory failure with fatigue. So before that, we should try to keep oxygenation by early intubation and intubation, but with very controlled manner, especially in COVID, because they ended up with other problems like pneumothorax. So exudative diffuse alveolar damage is the ultimate pathological entity. Then what happens is this proliferative phase. If the patient escapes exudative phase, they start this proliferative phase. So that is where fibrosis starts. That depends on the whole background, genetic and inflammatory, genetic background. So this is not very rare. I mean, this takes time and this is the ongoing kind of thing. If once the patient is discharged, this keep on active and sometimes once a patient is out of the, completely back to baseline and they later start developing subsequent lung damage. That I have seen quite few cases like that also. So what is the other type of post-COVID lung presentations? Now, these are actually interstitial lung disease categories. Usual interstitial pneumonia, organizing pneumonia, and lymphoplasmacytic interstitial lung conditions. Now, this usual interstitial pneumonia or UIP pattern was seen among these COVID patients. They tend to have this ground glass opacities with interstitial thickening and some reticulations. We get ground glass opacities when there is active inflammation going on, when there is cells and the exudate is there. Then we get this reticulation when there is fibrosis. So this is sometimes we can see mixed picture when the both processes are going on. Or one process can be dominant. Now, ground glass opacity, so active inflammation is more sensitive to medications, immune suppression. But the fibrotic phase is not very sensitive to immune suppressants. Uh, Now the presentation was very much variable. Then the organizing pneumonia is basically again it's soft tissue shadows, but more denser than UI, the ground glass opacities. But they are more patchy than usual interstitial pneumonia, especially subpleural, like arcade formation. Like I mean, that much of information is not needed for you, but I'm just trying to tell you that slightly different pattern, organizing pneumonia pattern. It's slightly more denser than ground glass opacities that represent multiple forms of inflammation or stages of inflammation. Ultimately, whatever the initial inflammation can ended up with fibrosis. I will show you how it happens in CT scans. Then this lymphoplasmacytic interstitial, where the lymphocytes are predominant. It's a slightly different form and more cells, more responsive to inflammatory immune suppression, actually. Lymphoplasmacytic form is more drug sensitive again. So these are few examples of presentations. But as in the interstitial lung disease, most of the time they are overlapping actually. They had kind of different CTs. Right. Just to show you that how they appear in the CT scan, because you might see them once in while in your practice these CT scans. You can see this ground glass opacities in the CT scan. Now, this black opacity is due to airfield spaces. Now, this patchy ash color area is due to infiltrates, the soft infiltrates. So, these are called ground glass opacities, and they are sometimes peripheral, posterior, and uh, patchy or even symmetrical, asymmetrical. That depends on the location of some genetic factors contributing and also multiple factors. So they are actually quite sensitive to medications and they might clear most of the times ground glass opacities. Not whole area turn into fibrotic patch. So it's a kind of battle between resolution and persisting as fibrosis. Then this fully fibrotic lungs. Now you can see it's like a honeycomb. We call it honeycomb lung. What happens is the contraction of the abnormal area and expansion of the normal alveoli. Now these holes are actually normal alveoli. It's not the other way around. What happens is abnormal or inflamed part get contracted. Ultimately, it ended up like a honeycomb. So these are not very efficient and these are basically non-functioning lung tissue most of the times. Then lung actually tries to expand, blood supply try to deviate, lung try to adjust, but if the damage is severe, this adjustment is not very optimal. Other thing is this causes traction bronchiectasis. That means this bands can expand the bronchi and causing bronchiectasis. So that also can contribute to lung symptoms. Other problem, they can overlap, as I told earlier. So both can uh, go on and on. So only way to differentiate is what we do is we repeat CT scans in a considerable time periods, and we compare with the previous scan, and we try to quantify what is really going on. Otherwise, there are no biomarkers, so any other way to objectively quantify the lung damage. We can functionally do it via spirometry and other functional lung testing also. So CT is plays a very good, significant or important role in identifying this ongoing lung damage in post-COVID lung also. But yeah, as I told earlier, as per the post-COVID trials, actually I was in some of the COVID immune, sorry, vaccine trials also like COVID boost. So what really the observations are actually, and also post-COVID clinics. We had separate clinics for some of the isolated category of patients who had pulmonary embolism and complications. So actually, some patients had resolution, significant resolution. But we were not sure what really causing that. Why some people resolve and some people having ongoing problem. Uh, like 16% had residual abnormalities, but still this is a significant number compared to other lung diseases or infections. Then moderate and severe COVID-19 are the ones actually falling into this ongoing lung damage, which we can I understand. They had this fibrotic changes, more ground glass opacities at discharge, and they more likely to develop later fibrotic lung. Now, radiological resolution, 42% at 1 month and 75% at 6 months. That indicates quite significant resolution as well. Still, some category go into uh, persisting fibrotic lung damage. So, identification of this category is not easy. I will tell you why it is not easy. Now, these are some of the at-risk categories. One way is to anticipate this problem. Patients with increased hospital stay, patients with high BMI, then patients who subjected to ventilation, prolonged ventilation, they were very difficult to extubate. Then patients with high certain biomarkers, high level of biomarkers, like C-reactive protein, lactate dehydrogenase, fibrinogen. So we could anticipate post-COVID lung in these patients, but we never used this criteria to get them back to the clinic. We basically went ahead with their CT findings and other general kind of presentation and the general status. And if they had the level of hypoxia was a key factor actually, whether they treated in the ICU or whether they were level of hypoxia, whether they were ventilated, whether they developed pulmonary embolism. So how we suspect? Now, one problem is we may not really ask about their previous COVID infection. If a patient comes to you with breathlessness, they might not tell you that they had COVID, or they have they will not think that it's related. That is also a problem. Sometimes they know it and they exaggerate. Sometimes they even will not tell you that they had COVID. So it's very important to ask about COVID history in this era. Still, we have COVID virus circulating in the pool. I mean, it's not disappeared, but the serious infection has disappeared. Still, we don't know this mild infection also causing certain amount of silent lung damage. No, I have not seen any trials or any studies on that. So if a patient has developed new or worsening symptoms after improvement, persistent symptom after discharge, or uh, if the radiological findings contrast with the symptoms, then we need to suspect and need to look at what else is happening. For example, COVID infection, we know that pulmonary embolism was a other key problem. So we should exclude pulmonary embolism in these patients. So respiratory, I mean, patient presenting with the similar symptoms. If we are not thinking that it's due to parenchymal, it's not. It's if it is disproportional to the parenchymal findings in the CT, then we should think of VQ imbalance due to pulmonary embolism. So this type of patients need CT angiography. Sometimes in UK, I think they did echocardiogram also, but I'm not sure very much sure about that. Why they did echocardiogram? They actually followed up with the echocardiogram as I remember. But if the patient, if they were not sure, they actually went ahead with the CT angiography. But I don't think this practice is not very relevant to our setting, as our embolism rates are quite low. But in UK, this is an important thing. Right. Now, as per the pathology, now diffusion abnormalities uh, are quite common after COVID-19 infection. You can understand that this air-blood membrane is severely affected in COVID. So that is why they get diffusion abnormalities. So their DLCO can be quite low with due to this fibrotic damage. Then sometimes diffusion abnormality tend to regress. When we do lung function testing with DSCO, sometimes we see an improvement. Now, if the patient is not improving after 1 year, then sometimes they might need advanced testing, which you may not need to know. And this, but they might need further assessment of the VQ imbalance. So, pulmonary functional physiology-wise, the restrictive pattern was the main pattern we observed. So decrease in all lung parameters like forced vital capacity, total lung capacity, forced expiratory volume 1, and DSCO. So all the parameters are low. That's a common feature in restrictive lung disease, restrictive pattern. Now, risk factors for diffusion and restriction impairment on pulmonary function testing after 1 year. After 1 year is quite, enough time to recover. So after 1 year means there's something going on. The risk factors of female sex, chronic kidney disease, mechanical ventilation, smoking, residual CT abnormalities, and length of hospital stay. So these are some of the risk factors which are helpful to identify at-risk patients or patients with prolonged COVID lung. So how now? I told you that it's very difficult to identify pure COVID lung. Now they present with exercise limitation, breathlessness, multiple respiratory complaints. So there are usually not single factor contributing to their symptoms. So it's very difficult to kind of properly uh, separate out their causes. Now, deconditioning is one key contributor to the persisting symptoms. That's due to, they were isolated, cut off from the normal working, and prolonged sick role and nutrition, hypoxia, the tissue hypoxia, muscle deconditioning, psychological factors, everything contributing to that. Their life, especially when the lifestyle is changed during the COVID era, so that affected people a lot. Then hyperventilation syndromes. This happens patients who are breathless. When they're anxious, they develop hyperventilation, and that is also not can be controlled by them. It's out of control. Then circulatory factors, especially in COVID, due to this thrombosis risk. Then, as I told earlier, perfusion ventilation mismatch due to embolism, fibrosis, as well as air blood barrier inflammation. So multiple factors. So how do we separate them out? Now, persistent ground glass opacities. Now, these are some of the already the pure pathological entities in the CT scan. But other than that, now we have this thromboembolism, deconditioning, cardiac injury, anxiety, and dysfunctional breathing. So we need to understand what is really contributing to patient symptoms. If patient has very obvious pattern in CT, it's not that difficult. We can simply do CT angiography and spirometry, and we can see how much it is, how severe. But when there are other things like cardiac injury, dysfunctional breathing, myopathy, it's not easy to diagnose them. So that was one problem. Problem is even if we treat them, they do not get much effect from the treatment. So that's the problem. Sometimes what we do is after initial evaluation, what we do is simple monitoring because most people tend to recover, as I told earlier. It's very difficult to decide at which point we should start treatment. If the patient has obvious thrombosis, then we start anticoagulation. Uh, if patient has existing lung disease, what we did was just continue their normal treatment without trying kind of over enthusiastic treatment options. One helpful thing was this rehabilitation. We also have in Sri Lanka some rehab capabilities, but in UK they had well organized rehab programs with physiotherapists and multiple teams. So it was quite helpful to get the patient back to normal social roles, addressing that psychological background. The thing is, some people have severe fibrosis, but that per se not contributing to symptoms. Actually, the psychological component is significantly contributing. So once we subjected them to physiotherapy, they improved quite well, and also psychiatric consultation. Now, that is why we need multidisciplinary in management, which is not very familiar in our setting, except in few diseases like lung cancer and certain other conditions. So in UK, it's mostly multidisciplinary. It's quite useful uh, to address multifactorial condition like post-COVID lung. Now, it will address, as I told earlier, mental, cognitive, physiological, and respiratory symptoms. The problem in our setting, we don't have very comprehensive programs. I don't know. One thing, we don't have proper post-COVID follow-up separately. Uh, Although we didn't have much of the affected population with severe lung and severe lung damage, dedicated services, still I think we can use our existing facilities for this type of thing if we correctly identify patients. One important thing is to ask about their past history of COVID. Then patient need careful monitoring, especially the category of patients with significant lung fibrosis or uh, persistent exercise limitation and symptoms. Now, this is a very basic flow chart for diagnosis. I don't think this is very relevant to uh, primary level. Now, if patient complains persistent symptoms, the assessment is like CT scan, lung function, and 6-minute walk test. If the diagnosis is clear, then it's better. We can channel the patient to rehab and other respiratory specialist pathways. But if the diagnosis is not clear, then we go for further testing. As I told earlier, echocardiogram, CT angiogram, and CPET, cardiopulmonary exercise testing. Cardiopulmonary exercise testing can identify circulatory causes and respiratory causes and other causes separately. So that is why that investigation is important. But we don't have to do all this investigation in each and every patient. We don't have to monitor each and every patient. That is why the screening is very important. Screening is not something really happening in our country. I mean, we don't screen patients properly. In specialist clinic, sometimes we see all type of patients. So in this condition also very important to pick the right patient and channel them in the right pathway. Now the potential therapeutic options, as I told earlier, nintedanib is not available, but from India we can actually, if we want, we can, import. Sometimes we do that, but for COVID lung we didn't use it much. So mTOR inhibitors, sirolimus, and this JAK inhibitors and interleukin 6 inhibitors are as I told earlier, those are suggested therapeutic options. But what is really helpful was steroids. Uh, and also, yeah, from initial stages even to this ground glass later stages, course of steroid help possibly helping some of the patients. So I think that is quite available in even our setting, and that is what we use even sometimes in terrible inflammatory lung disease, interstitial lung disease. As I told earlier, when there are more ground glass, more cellular component, more chance of immune suppression and suppression of lung inflammation and improvement of hypoxia. Sometimes when the lung inflammation stops, lung tries to get back to optimum status. Shift, as I told earlier, that lung will try to expand the air spaces, lung will try to shift the blood supply. That will improve EQ balance. So it will take time, and that's why we need some observe, keep on monitoring. So they will stabilize at one point. After that, that scars will not really matter. Scars will be there. To monitor scars in the lungs, we do repeat CT scans and see, try to quantify functional status. We do this lung function testing. So that's not that easier, not that same. I mean, not that difficult. If the patient is having symptom load, more symptom load, then we can try physiotherapy. If patient has more hypoxia, then the option is domiciliary oxygen, which is available in our country, but very expensive and troublesome. We have oxygen concentrated, we have home-based oxygen cylinders. Cylinders are very troublesome. They have to change it, and it's problematic. Oxygen concentrators, initial cost is high. So that's a problem. But if persisting hypoxia, that's the option. That will unload lungs, especially this pulmonary hypertension. If patient has developed pulmonary hypertension, it will help to unload the system and for long-term recovery. When there is no inflammation, that oxygen-mediated damage is less. So in this type of chronic lung, oxygen helps. So that's the other option for hypoxia, ongoing hypoxia. Now, what is relevant to our context? So we had less number of cases, obviously, and our severity also was less. Patients going into serious category ICU was less. So that's possibly due to the factors I already explained to you. Our genetic background, vitamin D, and having the viral pool circulating for a long time with similar viruses. But the pattern is similar because the virus is the same one. But we didn't have no data. As in any other condition, we didn't have reliable data available. So one important thing is to, as I told earlier, the history. History about past COVID infection, how severe it was, what happened, and what is the current status. What is the symptom burden? It's very difficult to separate the psychological component. I don't think we have valid questionnaires also to assess this part. Then do relevant investigations. No need to do everything for all these patients. Simple 6-minute walk test may be the initial starting point. Then possibly they need a CT scan or echocardiogram. Then timely detection is important because this is an ongoing problem. Earlier we intervene, better the outcome. So if a patient comes to you with unexplained worsening or unexplained new presentation of breathlessness, poor exercise capacity, then just ask about past previous COVID. Then referral to tertiary care. No need to refer all patients to just having, just because they had COVID, no need to refer them to tertiary care. Initial assessment, proper assessment at primary level is very important. Then only you should decide whether you should refer them to higher level, tertiary care level. Otherwise, tertiary care level become overburdened and everything will become a mess. Then the treatment of course happens at higher level after initial thorough assessment because steroids are not very, have significant side effects. So we decide what to do. If there are possible chance of recovery, then we try steroids. Then rehab programs, yes, we have a few and we can try them. Then as I told earlier, domiciliary oxygen. This is very difficult. If patient can afford, we can of course arrange. There are other ways of getting that, but now government is not offering funds, so it's very difficult if a patient is dying. If patient is dying due to lack of hypoxia, long-term hypoxia, it's a terrible thing, but sometimes very difficult to help. We don't have any programs to help that type of patients. Now you can see how COVID is different and how COVID is the impact tissue, the biology level and social level, symptom burden, and how COVID has impacted overall care and hospital level, and then post-COVID era, what has happened. Actually, the Viva vaccine was very helpful to get out of this problem uh, because it actually improved the immunity and spread of the condition. Actually, drug companies were very late to develop vaccines. They were expecting this infection to be clear before before vaccine is developed, but it didn't happen. And then there was a competition to develop vaccines. I think Pfizer had about 42% 42% profit, but later they then tried to kind of tail off their vaccine production with these trials. They try to give half doses and they try to develop for new strains. They kept some of the trial arms open for new strains in the same trial. So that's how they did it. And what I have heard is now they have all the technology to develop new vaccines at any point. So even if a new strain appear, they can develop vaccines if they want. Decision is with them. So I don't think COVID will become a pandemic again, but because of if they do proper vaccination, if strain emerges and vaccination is done. But now I think again there is a epidemic going in UK and US that is quite normal in that region. Compared to tropics. Even in the winter, they get this influenza and other viral epidemics, and their viruses are very virulent. That pattern is similarly seen in COVID, and deaths are also quite high. So multiple factors contributing. I don't think we will get a significant problem, but it's very important to take precautions before it becomes a serious problem. Because our respiratory general care is not very good. The spread is very high because of that. The general health habits and things are not very good in our country. So I think that's basically what I wanted to explain to you. I think this question comes in your Google form. Okay. So questions, you will get this MCQs in uh, Google form. I think if you have any questions, you can ask.
Sir, we got few questions before the lecture during the pre-survey.
Any questions?
Sir, we got these questions during the pre-survey. I would like to highlight some questions. Most of the questions you have answered during your lecture. What is the life expectancy in post-COVID lung fibrosis?
Yeah, actually, we don't have proper data even for uh, interstitial lung disease. It's highly variable. It depends on multiple factors. It's unique to the patient. We don't have data actually. Still, trials are going on these things, post-COVID trials. So we don't have data. Very difficult to tell a patient how long you will live. But we don't actually talk about these things in with the patients. We don't know actually.
Okay. The other question is, do lung transplantation is recommended for post-COVID lung disease?
Yes, yes, but it's for very selected category, especially young patients. One case I can remember, patient, young patient, that patient admitted during the peak day of admission. That day we had 500 admissions, 120 in the ICU. So this patient was a young patient with bilateral severe soft shadows, ground glass with bilateral thromboembolism on anticoagulation with bilateral pneumothoraces. So that type of patient, sometimes we refer them to multidisciplinary team and decide, try to, that this happened in UK, try to decide whether this patient is near, is case for lung transplantation. That's the acute stage. Then for chronic lung, if this fibrosis is severe, it's again no barrier for lung transplantation. It's quite similar to other chronic lung disease with serious severe hypoxia. So there is no limit, but practically it's not easy, especially our setting, I don't think. But UK also, if they get a proper uh, lung and if other things are quite fine, then there is no restriction.
Another question is in the chat box, sir. Can you elaborate on cardiopulmonary exercise testing, how it being done, and how to request for it?
Yeah, cardiopulmonary testing is a form of physiological test. It's a kind of treadmill test. And we monitor, while patient is treadmill, we monitor both cardiac parameters and respiratory parameters. For example, the ECG and various heart rate, blood pressure are measured. At the same time, we measure respiratory volumes like lung volumes, uh, oxygenation. These are measured parallelly, and the machine has a uh, uh, kind of a software which can analyze these things and separate cardiac and respiratory causes for symptoms, or whether both are not contributing to symptoms. So it's a very useful test. It can assess oxygen utilization by tissues and how this utilization is affected by cardiac versus respiratory. This is actually done in our respiratory clinics. At MRI respiratory clinic, we have a machine, and private sector it's been done. In the university, actually, I think we have a machine. It actually, you can simply uh, refer to the consultant asking for this test. Then the consultant will decide and refer to the physiotherapy, sorry, the respiratory physiology. Uh, it's separate. So respiratory consultant will refer. So what you have to do is asking for it and refer to the respiratory consultant. If you suspect both cardiac and respiratory causes, or if you are really not sure, actually this decision is taken by the at higher level by tertiary care level. Actually, I think that will explain to you basic things about
Okay.
cardiopulmonary exercise testing.
So there is another question in the chat box. Place for inhalers in the management of post-COVID breathlessness.
What is? Sorry.
Place for inhalers in
Okay.
the management of
Okay.
post-COVID breathlessness.
Right. Now, use of inhalers in our country is very irrational. Uh, so it's actually the inhalers are useful when there is reversible obstruction to small lungs, small airways. Uh, Here the pathology is restrictive and more lung parenchymal disease. What happens is when we give an inhaler, their psychological part improves, but there is not really, therapeutic impact from inhalers unless there is reversible obstructive component in lung function testing. If a patient had previous asthma or asthma tendency, then it might help. Just giving an inhaler will not really help unless it is the placebo effect. So what really happens is this placebo effect most of the time. So when the patient is breathless, sometimes people are clueless and they just give an inhaler. So unless there is an objective reason, there is no real place for inhalers.
Thank you very much, sir, for your excellent lecture and your precious time.
Okay, thanks.
Dear
So,
participants, you can find the link in the chat box for your CPD certificate. Kindly give your feedbacks and answer the post-assessment questions. Then you will receive the e-certificate for the participant. Thank you all for your participation.
thanks so much. Happy vacation and good luck.